So we have a switch. The presentation now would be by Jaclyn Hechtman. Jackie is an assistant member who's member of the GI team. She's GI molecular and the go-to person for all the GI molecular questions. I think her case also has a twist. Go ahead.
Thanks, Dr. Hamid. Before I start, I have to disclose a few additional things that just happened the last 2 weeks. So research funding from Bayer and other relevant disclosures include Axiom Biotechnologies honorarium and Core2 Ed for ESMO, or on behalf of ESMO. All right, so I do molecular and GI pathology, but this is not a GI pathology case. This is a 43-year-old female who presented without significant medical history with a right breast lump. And so they took that out, and here's the right breast lump. It's not so interesting, but don't fall asleep yet. So the biopsy in 2015 originally revealed invasive ductal and lobular carcinoma. The estrogen receptor was 90%, and it was strong. I can't show you the slides because they were sent back to the original institution where this was taken. It was also progesterone receptor positive, and the patient subsequently underwent a mastectomy, and she had positive lymph nodes, but no distant disease. So after her surgery, she went on to receive adjuvant systemic chemotherapy, as well as endocrine therapy with anastrozole, if I'm pronouncing that correctly, until October 2017. But then in October 2017, she unfortunately had distant metastases, and as you can see in this photo, estrogen receptor was negative. So we have a lymph node that's pretty much effaced by these pinker cells, which are all the breast carcinoma infiltrating throughout. And here's the ER. And then androgen receptor is expressed in the tumor cells, as we can see in this photo. So now she's got distant metastases, and you guys have heard about MSK Impact, our DNA-based next-generation sequencing assay. That was performed, and most of the results weren't too surprising. So GATA3 mutations and PIK3CA mutations are really common in breast carcinomas. However, we also see here at the bottom that there's a fusion between LMNA, which is the gene that encodes nuclear laminin, and NTRK, and the kinase domain of NTRK1. So since this is found on DNA, we want to make sure this is actually resulting in a transcript as well as a protein. So first, here's the IHC. And so we can definitely see that pan-Trk IHC is expressed in the tumor cells. They're cytoplasmic staining, but there's also perinuclear accentuation of the stain. We also did Archer, which is our RNA-based assay, and this came up with the fusion that we identified in the DNA. So it is produced as well, the LMNA and NTRK1 fusion. So in breast cancer, this is very, very rare, and it's also on the distant metastasis. So we went back and did impact on the 2015 mastectomy, and we can see it's clonally related, so it has the same PIK3CA mutation, the same GATA3 mutation. However, it's missing the LMNA and NTRK1 fusion. So we also did Archer on this, no fusions. And when we compare the IHC for pan-Trk, the mastectomy is dead negative, while it's diffusely positive in the 2017 sample. So to summarize, the 2015 breast cancer is clonally related to the distant metastasis, while the 2015 breast cancer is positive for estrogen receptor. The 2017 MET is triple negative. The 2015 breast cancer has no NTRK fusion. The 2017 MET has developed a clonal fusion, and I guess like in this case, the word that we would scientifically call this is a clonal sweep. And we tested multiple other sites for this patient because she developed multiple distant metastases, and all of them after October 2017 were positive for pan-Trk IHC and had a fusion. So as of October 2018, an update before we talk about what's happened, or the background of this case. The patient received a Tract inhibitor, and she's currently achieving a good response, so no new or increasing METs. all decreasing in size with resolution of FDG avidity. So to talk a bit about the background of this case, what we have here, at least with ER becoming negative, is not uncommon. It happens in about 1/4 of all patients who have breast cancer that was originally ER positive after endocrine therapy. This actually does have clinical significance. So we can see here in multiple analyses across multiple subgroups that not only at A and B, which are at breast cancer diagnosis, but also from the time of distant metastasis, loss of ER, which is the blue line, is related to a decrease in overall survival. While we might think it's a pretty rare and unique that this patient suddenly developed a clonal fusion after therapy, this has actually been described in other types of tumors, namely post-tyrosine kinase inhibition in EGFR mutant lung cancers. So this is a paper out of our institution by the lung team, and they have described that acquired fusions as a mechanism of resistance, namely here FGFR3 and BRAF. So now we're just going to touch on Tract fusions a little bit. They are characteristic of certain malignancies. The two ones that are most well known are infantile fibrosarcoma and secretory carcinoma. However, there's a long tail of other common malignancies that have very rare Tract fusions in less than 1%. So we see them in colon cancers, lung, breast, cholangio, a lot of sarcomas, different types of sarcomas. We've even had cases of AML and glioblastoma with Tract fusions. Not only this is important to now diagnose because there's therapy for it. So there's a recent paper that came out, also at MSKCC, about larotrectinib for Tract fusions. Around 80% of patients had a response to the drug, and the response lasted for a year or more. It was the median time. So now that we know it's important to test for Tract fusions in patients with advanced disease without a known driver, how do we do it? So we can look 3 ways: DNA, RNA, and protein. In the DNA, we can test via next-generation sequencing as long as the introns are tiled into the DNA. And since introns are long, this is somewhat challenging, especially in smaller panels. There's also FISH. The downside to doing FISH is that it only tells you that there's a rearrangement at the DNA level, but not that there's an RNA transcript or an actual protein that's being expressed. So a lot of the times we'll see something in the DNA that's a rearrangement. However, it's not a functionally active fusion. RNA, we've been using RNA with the Archer panel, and it's worked really well for us here. You can also do RNA-seq or TrueSeq by Illumina, which is a new panel that does DNA and RNA-based testing at the same time. And then protein testing can simply be done with Pantrac IHC. So we do that here, and it's now clinically validated. We have done a small study so far and are still working on it. And we've seen a couple different patterns when we have a fusion. It often localizes to where the partner gene is. So for example, ETV6 is a transcription factor, and it's often expressed at the nuclear level. TPM3 is a structural protein that's part of the cell membrane. And we can see here on the bottom that it's expressed at the cell membrane level. And here's another case of LMNA and Tract1 fusion, but this is a colon cancer. And it has the same exact pattern that we saw in the breast cancer. So that's the cytoplasmic staining as well as perinuclear accentuation. So just to summarize this case, loss of ER expression is relatively frequent at time of progression for breast cancer patients who are undergoing hormone therapy. It's actually much more common for patients who receive hormone therapy than patients who don't, and it portends a worse overall survival rate. Also, Tract 1 through 3 fusions are highly targetable, but that's if you can detect them, which isn't something routinely done for most cancers still. And in very rare cases, we're seeing reports this year, mainly, and going into the future as fusions are starting to be tested more often, that fusions can actually be acquired and become clonal. And once you catch them, then they can actually be something that the patient can be treated for. So that is the end of my talk. Thank you. Okay. Sorry.
So anybody has any questions?
So here, I personally do the IHC when we have a DNA level rearrangement that's not really characteristic on impact, since on impact we usually catch a lot of the fusions, but we also catch a lot of background rearrangements. Sometimes it can help, and I also do IHC if it's either has an outside positive testing in some way, or just the histology is characteristic of something like infantile fibrosarcoma or secretory carcinoma. I avoid IHC when there's any physiological expression of NTRK, track A through C. So that's anything that's smooth muscle or neurodifferentiation, because it's always going to be positive. So it's not very specific in those situations. So
for those who have the impact and then you do the IHC.
Yeah.
It's not like at the time of sign out.
No, yeah. So usually there's like a few situations. Either impact has a structural rearrangement that we would like to characterize further, or perhaps there's no driver. But it's usually the latter, structural rearrangement, that we would like to classify further. And sometimes they don't want to wait for Archer, which takes a couple weeks. This is one day.
In soft tissue tumors, though, sometimes based on the morphology, you can do it upfront.
I was thinking more like carcinomas and other unusual types of tumors. So how specific is the IHC?
So when you don't have neurologic or smooth muscle differentiation, I haven't seen it in anything else. Occasionally it's around the bronchioles, but those are non-dysplastic.
So if you have an IHC positive case, do you need to confirm with Archer?
I think it depends on the, I guess, like total level of evidence. So if you have an impact structural rearrangement that is suspicious and then you have IHC, a lot of clinicians here will just go ahead and give the drug and maybe order Archers while this is ongoing, but start things going as soon as they have the IHC result. And it depends who's reading the IHC result. So it takes a little bit of getting used to it. And so if someone has high confidence, and if a pathologist has high confidence in the result, then the clinician will often start treating.
So I guess you have to do your cases to know that IHC can be a surrogate marker for
Yeah.
the disease. Because generally this is a great fusion because almost every patient responds regardless of tumor type. So if IHC is the test, that's the best one that pathologists can
Yeah.
do. Not everybody can do IHC, but you need to
Yeah.
study.
Just you need to have a certain level of experience, just like ALK IHC. So this is a good parallel with ALK IHC. The only problem is that the physiologic expression issue is not good for some tumor types, but once someone has experience with it. So we'll also be publishing eventually a study that's much larger that highlights what this is best for and then the pitfalls of it, so that patients aren't treated when there's not a fusion.